Good afternoon, everyone, and welcome to the Myositis Association's webinar, Women of Color and Myositis. I am Linda Cobert, TMA's Research and Communications Director, and I will be moderating this session. I want to thank you for joining us on this webinar. Just a quick bit of housekeeping before we get started today. Phones will be muted for everyone throughout this presentation. However, we encourage you to ask questions. There is a chat box located at the bottom of your screen. You can type your questions into this box at any time throughout the presentation. We will have a question and answer period at the end of Dr. Johnson's and Dr. Stanoff's talk. This webinar is being recorded and will live on our website for future reference. I would now like to introduce Mary McGowan, Executive Director of the Myositis Association.
Thank you, Linda, and good afternoon, everyone. Welcome to the Myositis Association's webinar, Women of Color and Myositis. I'm Mary McGowan, Executive Director of the Myositis Association. For those of you who are not familiar with the Myositis Association, I want to spend just a few minutes providing a quick introduction to our organization. Next slide, please. The Myositis Association is the leading international nonprofit association supporting those living with myositis, their care partners, and the medical community and researchers who care for them. We were founded by a patient. Her name was Betty Curie. She was living with inclusion body myositis. And back in 1993, she began the organization with just 12 patients. And since then, we have grown to an international organization reaching thousands of patients and clinicians. Last year, we celebrated our 25th anniversary, and we are now an international collaborator of researchers advancing discoveries. Next slide, please. So it's a five-prong approach to what the Myositis Association does. We educate patients and their care partners and clinicians. We support patients and care partners and the medical community. We're located just outside of Washington, D.C., so we advocate for research and policies that meet the needs of patients. We fund critical research, seeking a better understanding and new treatments, and ultimately a cure. And of course, we increase awareness of myositis internationally with an emphasis on the medical community. Next slide, please. So we're very excited that Myositis Awareness Month has arrived. We have a number of special events going on, and one of our campaigns this year, of course, is Women of Color, which we are so excited to have you on this webinar today as part of that campaign. In addition, we have numerous special support group meetings throughout the country. I'm very excited. This coming Saturday, the San Francisco Giants are dedicating the game to the Myositis Association. And we're doing a number of awareness events at partner hospitals across the United States. We also have a very large social media campaign that we kicked off on May 1. We invite you to join us on this campaign. If you go to our homepage at myositis.org and click on the Myositis Awareness Month button, it will lead you to our homepage for the month, and there you will find a link to social graphics. So please help us send those throughout your social media channels to help raise awareness about myositis during Myositis Awareness Month. Thank you. Next slide, please. We are very grateful to the National Institutes of Health who helped us develop our Women of Color fact sheet and our social media graphics. We will send the fact sheet to all of the participants of today's webinar right after the webinar. We are also very grateful to our patient advisory board consisting of 12 women of color living with myositis who provided feedback on materials and on the campaign and advice on distribution. And TMA is also very grateful to Mallinckrodt Pharmaceuticals who helped make all of this possible through their very generous support of our efforts. Next slide, please. So at TMA, we like to begin with our greatest strength, and that is our members. I am honored to introduce Kanaya Gunter, who will share her story of inspiration and strength. Kanaya lives in Norfolk, Virginia, and has been a member of TMA since March of 2018. Kanaya became a support group leader in April of this year for the Virginia, West Virginia, and North Carolina areas. Kanaya is also a member of our Women of Color Patient Advice Council. Kanaya, we so much appreciate you being on today's webinar and sharing your personal story. Thank you.
Hi, my name is Kanaya Gunter. Hi, my name is Kanaya Gunter. I am a 35-year-old woman with 2 beautiful kids. I live in Norfolk, Virginia. I am here today to share the story of my myositis journey. I was diagnosed with NXP2 positive dermatomyositis in 2007. I also have calcinosis and overlapping of scleroderma. In June 2007, I noticed I was having difficulty eating, skin rashes on my face, chest, eyes, eyelids, and knuckles, and difficulty breathing. I lost weight. My muscles were getting weak, and I felt tired all the time. I also noticed that my eyes and skin were turning yellow. I saw 8 doctors before I was finally diagnosed. I was put on prednisone to help alleviate the symptoms, but I still was getting weak. I had trouble making my kids' favorite foods because I couldn't open the peanut butter and jelly jars. I was not able to raise my arm because of the hard and calcium deposits that were forming. While lying down, I needed extra pillows to support me. Just getting in and out of the shower or putting clothes on made me breathe extra heavy. This was a fatigue that I could not shake. My local doctors did not have the resources to manage my disease well. So in 2010, I was referred to the Johns Hopkins Myositis Center. I was evaluated by several specialists there and given a treatment plan. They confirmed the diagnosis to be dermatomyositis. Today, I continue to work closely with my local doctors. I have a new set of doctors who give me the tools to live well, including lifestyle changes like diet and mental and physical and spiritual strength. I feel totally blessed. One of the best connections is being part of the Myositis Association support group, where I can share ideas and personal experiences with others within my region and across the world. We help one another cope with dermatomyositis. Thank you.
Next slide, please. Thank you, Kanaya, for sharing your empowering story. It is now my honor to introduce you to Dr. Shalonda Johnson, Assistant Professor of Pulmonology at the University of Pennsylvania, and Dr. Sonia Danoff, Co-Director of the Interstitial Lung Disease Clinic at Johns Hopkins University and Associate Director of the Johns Hopkins Myositis Center and a member of TMA's esteemed Medical Advisory Board. Thank you, Dr. Johnson and Dr. Danoff, for joining us today to discuss the disproportionate impact of myositis on women of color.
Thank you very much for including us in this important discussion today. Next slide, please. I'd like to start off today by talking a little bit about what our goals are in this seminar, and we hope over the next 35 or 40 minutes we can cover this and still have time to respond to some questions that our audience might have. Our goal today is really to do several things: to provide an overview of autoimmune myositis, to discuss how autoimmune myositis can affect each individual, and then specifically to focus on the impact of this disease on women of color. I do want to say that this is really not intended to provide specific medical advice. That is much better provided by your own doctor. However, we will give you lists of resources that might help you to discuss some of these specific issues with your own doctor. Next slide, please. What I'd like to begin with is to start by just talking about what this idea of autoimmunity is, and then we'll focus in on autoimmune-associated myositis. And then I'm going to turn it over to my colleague, Dr. Johnson, who's going to talk about specific issues for people of color and some of the research that's very important in this area. And she'll also answer some of the questions that the advisory board had sent to us in advance of this to address some of the concerns that they had. Next slide, please. So let's start off with the basic concept of what autoimmunity is. So each person is born with essentially a defense system. This defense system is what we call the immune response, and its purpose is to identify things which are from outside of the body and are potentially a danger to the body, specifically things like viruses and bacteria. What happens with autoimmunity is that there's a mistake that occurs where the immune system begins to see a part of itself as being potentially dangerous, and it forms a response against a part of the self. So the immune system leads to inflammation in the tissue, and then there's damage and injury. We know that this immune response can have a number of different causes. Sometimes we can identify the cause, but often we actually can't identify what triggers the autoimmunity. Nevertheless, we can often detect autoimmunity because much like when the body is vaccinated against bacteria or a virus to provide immunity, when the body is vaccinated against itself, it produces something called antibodies. And when these antibodies are against a part of one's own body, we describe them as being autoantibodies. And those allow us to recognize when an individual has had this phenomenon of autoimmunity and their body has essentially created a response against itself. Next slide, please. So that's the idea of autoimmunity in general. So now let's focus in on myositis. So within the category of myositis, there are a variety of different groups that we recognize. So some people have myositis that affects just their muscles. Sometimes it affects their muscles and their skin. Sometimes the lung is affected. Often the joints are affected. So because there are these various presentations of myositis, we've created different names for them. Dermatomyositis typically means that the skin is involved. Polymyositis tends to mean that the skin is not involved. In addition, this is a disease that can affect young people as well, and we describe that as being juvenile dermatomyositis or polymyositis. Myositis can occur in and of itself, but it can also occur in the context of other autoimmune diseases, as you heard from Kanaya earlier. So it can occur with other diseases like scleroderma or lupus or mixed connective tissue disorder. Finally, there are some forms of myositis that are described as necrotizing myopathy, that is, where the muscle itself is actually dies as a result of the injury. Next slide, please. So I've mentioned that autoimmune myositis can really present in a variety of different ways, and I think that the one truth is that every person is different, and so each individual will have some number of these symptoms, maybe not all of them. Some people might have all of them, but some of the cardinal features are muscle weakness or pain, and that gives the name myositis. There's often also involvement of the joints, which we call arthritis. Some people have skin rashes, which brings the name dermato into it. And many patients are affected by lung disease, that can happen in any of these forms of myositis. Next slide, please. So you might well wonder, how is it that patients are diagnosed with autoimmune myositis? And I know that for each of you, your pathway has been different. And so this may not be exactly what happened, but this is, in general, the way we approach it. The first and most important thing is actually to listen to the patient and hear about what's happened to them, and then very carefully examine them for some of these features that we recognize as being part of myositis. We'll often send blood tests as well. We'll send these antibody markers that I mentioned earlier, as well as markers of muscle damage like creatine kinase or CK and aldolase. Sometimes we want to get a better look at whether the muscles are involved, and we might do an MRI of the muscles or do an EMG, a nerve conduction velocity, to see how the muscles are functioning. Sometimes we need to do a biopsy, and this might involve biopsying the skin if there's a rash, or the muscle if the muscle is weak. And then if there's a concern about lung involvement, we do testing related to the lung. So we might get a chest x-ray or a CT scan, and we might do tests to measure the function of the lung called pulmonary function tests. Next slide, please. Now, once a person is diagnosed with autoimmune myositis, that's just the start, because obviously many patients are going to require therapy. And one of the most important jobs that the doctor has after a patient has been diagnosed is to make sure that the therapy is working. And so it's really important to monitor the disease activity. So these are also done in different ways. If one of the major components is muscle inflammation or damage, then we might check a strength exam and measure how strong the muscles are, or we might check those labs, the CKs and the other muscle enzymes, to see if those are going up or going down or staying the same. If there's lung involvement, it's very important to monitor how the lung is being affected. So we listen to the lung, we do a series of tests, these breathing tests or pulmonary function tests, that give us a very accurate measure of how the lung sizes are and how well the lung is absorbing oxygen from the air. Usually we don't have to do CTs or chest x-rays on a regular basis, but we might need to do that if there's an abrupt change in symptoms. And if there's rash, we typically look at the skin, and we can use a measure called the CDASI to determine how much of the skin is involved and how severely. Next slide, please. Now, I talked a little bit about the fact that we're monitoring whether treatment works. So now let's talk about what is treatment. Well, we know that the process that goes into forming this disease is that there's often a combination of some trigger, something in the environment, maybe an infection or exposure to a medication or stress or something we don't yet know. And it typically occurs in a susceptible person. So we know that some families are more likely to have autoimmune disease than others. So we think that there are genes that tend to make a person more susceptible to developing it. If there's the combination of the trigger and this genetic predisposition, then an abnormal immune response happens, that autoimmunity that I mentioned earlier. And that autoimmunity leads to the production of factors that damage tissue, and that causes inflammation. That results in the muscle weakness, the rash, the difficulty breathing. By using immunosuppression, we can block the immune response and therefore try to limit the amount of tissue inflammation that takes place. Now, this form of immunosuppression is going to be different for every person, and it might be that some people don't need to use these medicines, but many people do. Next slide, please. So when we talk about the medications, they vary as much as every individual because each person needs a different combination of medicines in order to make their disease better. But often the medications include prednisone or another corticosteroid. I'm sorry, I just lost the slides. Other medications include immunosuppressants that might be like methotrexate or azathioprine, mycophenolate. There are many of them, and the decision of which one might be used or might be necessary will depend on the individual and will be a discussion with your provider. Sometimes we use topical medications, especially if there's rash. Finally, for some patients where the medicines that are taken by mouth are not sufficient, we might go to an infusion medication like immunoglobulin or rituximab. In addition to those medications, we also want to make sure that we're taking care of the bone strength of people who are taking these medications, that we're using sun protection to limit the amount of damage the sun can do and the sensitization that can happen from some of these medications to the sun. And we absolutely want to limit the risk of infection by making sure that people are vaccinated for common infections, and that if they're taking certain medicines that might put them at risk of particular infections, that they're taking appropriate prophylaxis to prevent them from getting those infections. Next slide, please. Now, those are not the only things, though, that help our patients, and I think that we can't emphasize enough, and you heard this also very nicely from Kanaya, that there are so many things that a patient can do for themselves. We absolutely encourage our patients to exercise regularly to help maintain their muscle strength and keep their frame strong. We want people to maintain ideal body weight because some of these medications can tend to cause some weight gain, and the decreased muscle strength can cause people to be less active. A healthy diet is a key for everybody for maintaining their good health. And then mindfulness, because this can be a very stressful disease, and we know that stress plays into the propagation of autoimmune diseases. Next slide, please. I'd like to turn it over now to my colleague, Dr. Shalonda Johnson, who's going to focus in on specific issues related to patients of color. Thank you.
Thank you, Dr. Danoff. I wanted to spend a little bit of time highlighting some of the features of autoimmune myositis that are specific to patients of color. And I'm going to focus specifically on diagnostic delays, differences in how myositis presents in minority populations, and how outcomes differ, especially in African American women. Next slide, please. And so one of the questions that we get commonly from our patients of all racial and ethnic backgrounds is, why is there often such a long time between when symptoms develop and when a patient is diagnosed? And the answer is complicated, but I've highlighted some of the more commonly cited factors here. Firstly, myositis is a relatively uncommon condition. If you look at polymyositis and dermatomyositis, each affect about 1 to 20 people per 100,000 each year in the general population. And so to put that in perspective, there are about 327 million people in the United States. And so this is not a common condition. And as a result, there are many providers who have never encountered a patient with myositis. And when you go outside of specialty centers, physicians are less familiar with the symptoms, the diagnostic evaluation, or even how to treat the disorder. And you can couple this with the fact that, as Dr. Danoff mentioned, how the disease presents varies between patients, that the presentation sometimes is very subtle or often mild, and that the symptoms can overlap with other more common autoimmune disorders, and it's easy to see why delays in diagnosis are not uncommon. Finally, because this is a multi-organ, multi-system disease, it really depends on what type of specialist you see first in terms of their familiarity with the disease. And so a rheumatologist versus a pulmonologist or a dermatologist will really make a big difference in terms of how quickly you get diagnosed. Unfortunately, all of these challenges can be magnified in patients of color. One of the more obvious reasons why is just recognizing the rash that we can see in some forms of myositis in patients who have more darkly pigmented skin. I've included a photo here of a heliotrope rash, which is basically where there's purple or red discoloration of the upper eyelid that is useful sometimes in distinguishing dermatomyositis. And you may be able to appreciate that the rash is not as obvious in the woman with the darker skin compared to the Caucasian woman next to her. And this can be especially true for providers who are not specifically focusing on your eyelids when they examine you. And lastly, the antibody markers or blood tests that we send to look for myositis can differ significantly in African Americans. And I'll highlight this in more detail later in the presentation. Next slide, please. And so multiple studies have shown that autoimmune myositis is more common in African Americans. One of the more recent studies looking at this was performed in 2012, and they looked at all new myositis cases in the United States between 2004 and 2008. And what they saw was that 43% of those new cases were in African Americans, 38% were in Caucasians, with a much smaller proportion in Hispanics and other racial ethnic groups. When we look at the types of antibody markers that physicians send to look for myositis, we know that this can differ by race. And so one important example are the anti-synthetase antibodies, which are common in patients who have lung disease. And although anti-Jo1 is the most common in all racial groups, African Americans who have myositis are much more likely to have a non-Jo1 antibody, such as anti-PL7 or anti-PL12. And this was a problem, especially in the community, when the myositis blood panel test was not as comprehensive, and physicians were only sending a Jo1. And this often resulted in a delay in diagnosis in our African American patients. Unfortunately, interstitial lung disease is more severe in African Americans who have autoimmune myositis. They tend to present at a younger age with more severe lung involvement and more symptoms. And then finally, when it comes to genetic risk, to quote Maya Angelou, we are more alike than we are unalike. And this is true about genetic risk across all racial groups. Genes that influence risk tend to be the same for all of us, but there are some unique genetic signatures that we see in African Americans and Hispanics that could explain some of the differences that I just described in how the disease presents in these groups. Next slide, please. And so how does this influence prognosis in non-white patients? And so one thing that we do know is that non-white women are hospitalized more frequently and tend to stay longer in the hospital. And there are several potential explanations for this. One is just that we know that African American women are more likely to have myositis, so it's not surprising they would end up in the hospital more. I just mentioned to you that some forms of the disease can be more severe in African Americans. But you can't downplay that there may be some relationship also to just societal inequities and access to healthcare that are playing a role in this as well. And I think that we need better studies to really flesh this out and understand why this is the case, and also to figure out how we can intervene and fix this. Historically, mortality rates have been higher in non-white women. So non-white women with myositis are more likely to die than their European American counterparts. And the figures listed here are based on older data that comes from the 70s and 80s. And to put this in perspective, I can tell you that the group at the Johns Hopkins Myositis Center looked at this recently in about 800 patients with myositis. And they did not see a difference in mortality by race, which doesn't mean that one doesn't exist, but I think it just shows that over time there were such small numbers of deaths in this group that they weren't able to actually see a difference by race. And so I think that this needs to be re-examined in the current era. Finally, I just want to make a point about childbearing years. So this is a high-risk period for all women with myositis, both white and Black. The incidence of myositis in women overall is 2.5 times more common than men. So for every 2.5 women with myositis, there's 1 man. However, if you look at women of childbearing age, so between 15 and 34, this increases to 5 women for every 1 man. And so this is just a high-risk period for women. And so when you look at this statistic about non-white women who are of childbearing age being 3.5 times more likely to die, I think you're seeing the fact that African American women have higher risk in general, and that there's something about this time period in a woman's life that's really high risk for autoimmunity. Next slide, please. And so how can we do better? And I think that, one obvious way to do better is just to improve our research efforts around the field. And so I can tell you that, there are several patient and physician societies who are pouring a lot of resources into trying to understand myositis more completely. And this includes looking at how does myositis behave over time in different groups of patients. We've already mentioned several times antibody markers, and we think that this is an important way of looking at patients over time. What are the factors that influence prognosis, and how can we improve survival, especially in African American women? Are there new or less invasive ways to establish a diagnosis and to make the diagnosis more quickly? There are several ongoing clinical trials looking at medications and also physical therapy approaches for patients with myositis. There are also studies looking at environmental risk factors and how we can mitigate that for patients with myositis. And then finally, a plug for my specific area of interest, which is understanding how genes influence who develops myositis, who doesn't develop myositis, with ultimately the long-term goal being to develop new therapies for our patients. Next slide, please. And so as Dr. Danoff mentioned, we were fortunate to have some input from our TMA patient advisors in advance about topics that were important to them. And so this list is certainly not exhaustive, but anything that we don't cover now, we can attempt to address during the question and answer period. Next slide, please. So the first question was about increasing physician awareness. And I think that this ties back into the issue I discussed previously about diagnostic delays. And so there are several organizations that specifically focus on rare diseases, including this one, the Myositis Association, but also there are organizations of rare disorders and other physician and patient groups that are really working hard to raise awareness. And they're doing this through a variety of methods, both using social, broadcast, and print media, working with physician groups, and going out into the community and educating people like at local schools. And this has really been a joint effort between the medical community and also patient advocacy groups. It's also very important, though, for physicians who have expertise in myositis to be very active in their respective national and international societies. All of these societies hold annual meetings, and this is really a great opportunity for physicians to educate other physicians about ongoing research and in issues that are specific to their patients. On a more grassroots level, each time a community physician refers a patient to a specialty center, this is an opportunity for us to educate them about rare diseases. And lastly, I think that strong research studies that are published in widely read medical journals is a great way to increase awareness among physicians. Next slide, please. So we were asked to discuss hypophosphatemia, or low blood phosphate levels. There are several causes for low phosphate levels. Generally, though, in most of our patients, this is due to some other disorder and not a problem with the way the body actually processes phosphate. Symptoms due to low phosphate level are generally only seen in patients who have very, very severely low levels. And muscle weakness can be a symptom, though, of having a low blood phosphate level. And usually we treat the underlying cause versus giving the patient more phosphate. One of the more common secondary causes that we see here in the United States is a low vitamin D level or vitamin D deficiency. And this can be exacerbated in our patients who have myositis because of little sun exposure. And the lack of sun exposure could be because of their underlying condition, but also, as Dr. Danoff mentioned before, we advise our patients to limit their sun exposure for a variety of reasons, and this also can exacerbate vitamin D deficiency. There are some medications that can bind phosphorus and prevent it from being absorbed, and these include things like antacids that have aluminum or magnesium, such as milk of magnesia or Maalox, especially when used in heavy quantities. This is something that we don't see as commonly anymore because many of our patients are using medications like Prilosec or Nexium instead. Lastly, I'll mention a condition called hypophosphatasia, because this was posed to us by one of our patient advocates. This actually doesn't cause a low blood phosphate level, but rather a low blood alkaline phosphatase level. And it's a very rare genetic condition that causes thinning of the bones, periodontal disease, and it's because of the lack of an enzyme. Next slide, please. And so calcinosis management was also raised by several of our patient advocates. And basically what calcinosis is when the body deposits calcium either in the skin or other soft tissues. And the way that this affects a patient can vary significantly. Some patients will be asymptomatic, and this will be an incidental examination finding, where other patients will have pretty severe symptoms and can have a lot of pain and disability related to their calcinosis. I can tell you that treatment is often challenging, but we do have treatments available. Because this is associated with autoimmune conditions, especially things like scleroderma or myositis, the mainstay of treatment is really managing that underlying autoimmune condition. We do, however, have specific medications that we use to either target calcium in the body or inflammation in the body. And I've listed 3 commonly used medications here. I can tell you that there's an active clinical trial that's currently ongoing at the NIH looking at an alternative medication treatment for calcinosis in patients with both adult and juvenile dermatomyositis. And for some patients who have discrete areas of calcinosis, surgery is sometimes an option. Next slide, please. We were also asked to just inform our patients about what is neuropathy. And so generally speaking, this is any disorder of the nervous system. But I think that more often than not, when someone uses the term neuropathy, they're either referencing peripheral neuropathy, which is also sometimes called polyneuropathy. And this is a condition that causes numbness and burning pain in the extremities. There are many potential causes, way too many for me to actually detail here, but I can tell you that chronic illnesses like diabetes are very common causes. You can also see in people who have autoimmune conditions like myositis, and sometimes they're related to very treatable vitamin deficiencies like vitamin B12 or folic acid deficiencies. You're probably noticing a theme here, which is that the treatment is targeting the underlying condition. And so if you have autoimmune myositis and that's the cause of your neuropathy, then you treat the myositis. I mentioned that pain is a common symptom, and we do have medications available that have been used with varying levels of success to treat pain, such as gabapentin or Neurontin. Patients also want to be thoughtful about minimizing potential complications. And one common complication is foot ulcerations. And so we recommend that patients who have involvement of their feet regularly see a podiatrist. Next slide, please. One patient advisor asked us to discuss the evaluation for elevated liver enzymes. And so I've listed the liver enzymes that we commonly screen for. And when we're looking at elevated liver enzymes, the pattern of the elevation is very helpful to doctors in terms of thinking about the potential cause. And this is very important because just like neuropathy, when it comes to elevated liver enzymes, there are many potential causes. I've listed some of the more common causes here. I can tell you though that in patients with myositis, there will be 2 things that I want to think of pretty closely to the start of the elevation in the enzymes. The first would be, we know that the aminotransferases, so that's ALT and AST, are not specific to the liver. And so these enzymes can also be found in skeletal muscle. And so the first question I would have in a patient who has elevated liver enzymes that has myositis is, what is the CK? Is the patient having muscle weakness? Is this really a muscle problem and not a liver problem? Further, many of the medications that we use to treat myositis, such as methotrexate or azathioprine, can irritate the liver. And so sometimes in a patient, it's as simple as either stopping the medication or reducing the medication to actually look and see if their liver function test will improve. And then, of course, in the background, we're thinking about all the other potential etiologies. But usually, I would exclude those two more common explanations first before going through a lengthy evaluation with additional blood tests, imaging, and then rarely a liver biopsy. Next slide, please. Finally, we were asked to discuss toxic myopathy. And so toxins can cause injury to the muscle in 3 different ways, either directly, indirectly, or by inducing muscle inflammation. And I've listed some of the potential causes of direct muscle injury here. I wanted to spend a little bit of time talking about glucocorticoids like prednisone and statins. And so prednisone is a fantastic medication that we very commonly prescribe, but it can be problematic when it's used at high doses for long periods of time because it can cause a myopathy that can result in significant muscle weakness that can take some time to resolve even once the prednisone has been removed. Statins, which are medications like Lipitor or Crestor that are commonly prescribed to treat high cholesterol levels, can also cause muscle injury. And they can cause muscle injury in 2 different ways. They can directly injure the muscle, although severe muscle injury from this method is usually rare, and this resolves when you stop the medication. They can also cause basically an autoimmune response within the body in people who have certain genes. And these patients have antibody markers to a specific enzyme called HMGCR, and they respond to immunosuppression like patients with traditional forms of myositis, such as polymyositis and dermatomyositis. Next slide, please. So in conclusion, I think that the take-home message today is that autoimmune myositis is a rare disorder and that it can present very differently from patient to patient. We have available treatments, but more targeted treatments with fewer side effects are definitely needed. This is a condition that is more common in African Americans and women and can have more severe consequences in that patient population. Awareness is improving. I think that we have done a good job in the past several years, but certainly we have a way to go. But at the end of the day, I think that there are reasons to be optimistic, including the fact that there are several exciting areas of research that are currently ongoing. And so with that, I'll say thank you, and I'll give it back to Linda.
Next slide, please. Thank you, Dr. Johnson and Dr. Danoff. We will now start to our question and answer session. As a reminder, participants can ask a question by typing it into the chat box at the bottom of the screen. I will be helping to facilitate today's question and answer session, and we will start with this question. So what can African American women or women with color who have myositis, what can they do to decrease the risk, their risk for these health conditions?
So I think that question gets at the root of what do we think is the cause for this condition. And so I think it's a question about prevention. And so at this point in time, I think unfortunately we don't have a lot of conclusive information about the specific causes in women of color. And so right now our whole intervention campaign is really targeted about early diagnosis and early initiation of effective treatment. But currently we don't have any known preventative strategies. But it's something that we're working on.
Well, that's good to hear.
Yes.
Are all women of color more at risk for interstitial lung disease? So
no. What we know is that interstitial lung disease is not seen in all patients with myositis. So if you take all comers with myositis, we think clinically significant lung disease happens in about 10% of patients. But if you look at specific subsets of patients, for instance, those who have that specific antibody I mentioned before, the anti-synthetase syndrome, those patients, their risk goes up much higher. So anywhere between 60 and 80% of those patients will have lung involvement with varying levels of severity. And so the answer is no, that not all of our African American women patients will have lung involvement.
Thank you.
Mm-hmm.
We have a question that from someone with inclusion body myositis, and who wants to know if this information is relevant to IBM.
Yeah, so the things that we discussed today were specifically targeted at types of myositis that did not include inclusion body myositis.
So do you ever see patients who have elevated LDH as opposed to CK?
Yes, and so LDH is another one of those enzymes that can come from both a problem with the muscle and a problem with the liver. And so generally it's another type of muscle enzyme that we would send. And sometimes it reflects a muscle injury, but it can reflect other things as well, like I mentioned, a liver injury. But it is something that we send, although not routinely when we're doing surveillance monitoring, but early on in someone's diagnosis, an LDH could be sent.
Thank you. We have somebody who's asking about clinical trials and research efforts that are being made to find new treatments. Can you talk a little about some of that?
Yeah, so one great resource for patients who are looking for clinical trials, besides websites like the Myositis Association that I know link out to clinical trials, is a resource called clinicaltrials.gov. All clinical trials are registered, and so this is a good place to look for clinical trials related to your condition. And so you can just type myositis into the search box, and it'll show you a list of all of the trials that are actively recruiting patients. And you can look and see if one looks interesting to you, and you can always contact the research coordinator who can give you more information about whether or not you qualify for the study. And if you ever have any questions about a particular trial, I would say to go back and ask your provider. But usually the research coordinator will be the best resource for information. And so again, that's clinicaltrials.gov.
Thank you. Someone would like to know if exercise, CellCept, and prednisone can help enough to improve ILD with polymyositis, enough to eliminate the need for oxygen.
It depends. So I would tell you that so exercise is always a good thing. So I would never discourage someone from exercising no matter what's going on. The need for oxygen is complicated. And so we know that people who have lung involvement from myositis can have varying levels of inflammation and scarring. And so inflammation can be reversible at times, but scarring cannot. And so depending on where a patient is in their disease course, that will determine how much of the disease is actually reversible. And so someone who's had disease for a long time, who has a lot of scarring, may not have a lot of reversible disease. And so our treatment in those patients are generally targeted at preventing them from having progressive disease or worse disease. And so we want to stabilize their lung function. And so even if we stabilize their lung function, if they came to us already requiring oxygen, we may not be able to get them off of oxygen. Some patients may present earlier on in their course who have a lot of inflammation that we're able to reverse with treatment. And in those patients, we can often get them off of oxygen. So the answer really is that it depends. The three things that that patient mentioned, exercise, CellCept, and prednisone, are all good. But as Dr. Danoff mentioned, the treatment plan is going to vary between individuals, with the exception of exercise, which I think is good for everyone. Everyone should exercise.
And I think I would just add one other point to Dr. Johnson's summary, which I think was wonderful, is this is actually part of the reason why we're so focused on trying to have patients diagnosed quickly, because we do think that the earlier we start to treat the interstitial lung disease, the better the likely outcome will be. Yet another reason why we really want to increase the awareness of this disease and have patients get to treatment faster.
Thank you. So a dermatomyositis patient would like to know, is it common for skin to darken and become blotchy over time? She's noticed that this has been happening for her.
Yeah, so this can happen. It's not universal. Unfortunately, sometimes one of the signs of damage to the skin is hyperpigmentation, especially in people who have more darkly pigmented skin. And so this is something that is a result of having inflamed skin for a long period of time that's not treated. So kind of highlighting Dr. Daniel's point, another reason for early intervention. But this doesn't happen universally in all patients, but unfortunately, sometimes having these more darkly pigmented spots can be a sign of previous skin injury.
Thank you. Is methotrexate an option for myositis patients with ILD?
So this is an excellent question. So the short answer is yes. And there's a lot of hesitation about using methotrexate in patients who have lung involvement because in a very small group of patients who take methotrexate, they can get an inflammatory response in the lungs that can mimic their ILD. And so one of the reasons why we avoid the medication is that we would like to not cause confusion if someone has worsening symptoms and worsening CT scans as to whether or not that is because their myositis ILD is getting worse or this is just a toxic reaction from the methotrexate itself. But that being said, we do have patients who have lung involvement that's not very severe and whom methotrexate works very well for treating their joint disease or arthritis. And so we will permit the use of the methotrexate, but we just ask that we watch them closely to make sure they don't develop any new lung symptoms. And in that case, we likely would stop the drug right away. But it's not a universal no-no, but I think that patients will find that in general, we do tend to avoid it.
Thank you. This person would like to know what the relationship is between the lab tests, the CK level, SED rate, and CRP. Apparently her CRP is generally elevated while the other tests are usually normal.
Yeah, so I can tell you that CRP and the SED rate, so these are blood tests that we send that are general markers of inflammation. And so they're not specific to any type of disease, and they're not even specific to autoimmune diseases. So you can have high levels of CRP or SED rate with other things that cause inflammation in the body, like an infection or a cancer. And they're not always specific either, or they don't always coordinate with disease activity. And so I find that they can often be misleading, especially when they're being followed serially over time. And so I think that this patient's experience of there being a lack of coordination between what the CK level is and what the CRP is not uncommon. And I would say that that person would need to, review those results with their physicians to see if they really think that that's reflecting disease activity, or if it's just the fact that that test is just not very specific to what we're measuring, which is activity of the disease.
And I might just add one other point, which is that we often see in patients who have interstitial lung disease that they have completely normal CKs. And again, this is part of the education we talk about when we're trying to help community physicians think about this as being, the lung disease as being part of this disease which has been named around muscle involvement. Not every patient who has the antibodies that define myositis actually has muscle involvement. And so sometimes the diagnosis can be delayed if the CK level is low, even though the patient has other manifestations such as skin rash or lung disease. And so we really, again, think that these have to be taken in context. The fact that the CK does or doesn't go up or doesn't correlate with the SED rates or other markers doesn't really tell us anything. It only tells us that in that individual, it doesn't seem to correlate with disease activity.
Thank you. So this question is from a patient who is a woman of color who has been diagnosed with dermatomyositis and also diagnosed with ILD, but the ILD is not active. So what does that really mean, that she has ILD, but it's not active?
Right. So basically, it means that we don't think that there's any ongoing injury to the lung itself. And so usually when we think a patient doesn't have active lung disease, we're basing that on symptoms, their lung function tests, or are the lung function tests stable over time, and their exam. And so in patients who have had evidence of lung disease on imaging, but who have stable symptoms and stable lung function tests, we often say that that patient's disease is not active. Now, that doesn't mean that it can't become active again over time. And so I think that close follow-up is still necessary. But certainly we have patients who will have lung involvement that is active at one point in time, but does not remain active. And that could be to treatment or some other patient factor that we don't quite understand that leads people to over time have less active disease.
Thank you. Here's a question from someone who wants to know if there are resources that can be shared with doctors, with I assume personal doctors, to help them understand the unique presentation of myositis in people of color. Perhaps one response to that question is to share the recording of this webinar with your doctor so that they can hear this presentation. Are there other ideas?
So no, I think that that's a fantastic resource, as I mentioned. And then there are resources through other physician societies, depending on what type of physician it is. So there's several groups that are focused on myositis that also have lists of resources as well. Maybe it's best that maybe we'll include a summary statement of that on the webinar in the future that lists the different areas that physicians can go to get information. Dr. Danoff, did you have any specific thoughts about places where physicians should go to get more information?
No, I agree with you completely. I think that the nice thing about TMA is that it really sees the disease as a whole. For many patients, they are diagnosed because of one aspect of their disease, either their muscle disease or their skin rash or their lung disease or their joint disease. And so each of the individual areas, dermatology, rheumatology, neurology, pulmonary, we each have areas that provide information. And I think that the Myositis Association has very nice umbrella information, and particularly the information that was developed for this campaign, I think would be very valuable to share with your doctor.
Thank you. So this is a question that refers to the toxic myopathy question that you responded to earlier, Dr. Johnson. And the question is, if alcohol is a toxin, does it mean that it's only in excessive quantities, or is social consumption also a trigger?
Right. So we're definitely talking about high-risk alcohol consumption, which for women actually is less alcohol than you would think. And so at-risk drinking for women is considered 2 or more drinks a day. But social use is not a problem in terms of myopathy. This is really in people who have heavier levels of consumption.
Thank you. We're having a little conversation here about the resources for doctors. As Dr. Danoff pointed out, that TMA does have a page on our website about this issue, women of color. That can be a resource. Part of that page includes an infographic that easily represents many of the issues that are a problem for women of color that would be easy to share with a physician. And also TMA has a medical advisory board who is noted on our website, who are very knowledgeable specialists in various areas who are willing to be contacted. Okay, so oh, here's one more. This person wants to know if there's an assistance provided to myositis patients in terms of gaining medical insurance, especially because the disease is categorized as a disability. And I think that that's a question that is not necessarily for our presenters, but you can find information about that on TMA's website, as well as during, we will have specific sessions about that during our annual patient conference. Which is in September in Minneapolis, and the registration and information can be found on our website about that too. And so we have arrived at 1 o'clock, and we will call our webinar to a close. Would you please advance to the next slide, please? We have lots of information on our website, myositis.org. The information about Myositis Awareness Month, which also includes the Women of Color campaign, is on the website also, that's listed there. We encourage people to spread the awareness through their physician and on their social media, and also to join us at TMA and become a member. It is absolutely free. Please remember to complete a short survey that will be sent to you by email after this session. Next slide, please. And here is information about our annual conference, September 5th through 8th in Minneapolis. We have a sneak peek preview webinar that we did the other day, and you can view you can hear the recording of that at the website that's listed here. And by the way, we will send this recording to everyone who has registered for this webinar, so that you'll have these email links that you can go to. Next slide, please. And one of our Myositis Awareness Month events we are excited about is happening on Saturday, May 11th, this Saturday. The San Francisco Giants are dedicating that game to TMA. And we're pleased to announce that Kezar Life Sciences will be matching donations that are made on May 11th up to $5,000. So we encourage anybody who is on the call to make a donation and double your impact. Next slide, please. We also have a focus on Mother's Day, which is Sunday. And if you are posting on your social media about Myositis Awareness Month, we have these specific graphics that are available for you to download on our website, and we encourage everyone to do that and to use some of these hashtags and handles. So next slide, please. Thank you all for joining us. We are happy to share this information with you, and please respond to the email that you will receive in the survey in your email. Thank you.